Hello everyone, it's my great pleasure to give a talk to KDD 2020 Housing Day. My talk is about rolling interventions for controlling COVID-19 outbreaks in the UK to reduce healthcare care demand. I'm Paul Yang from Sheffield University. This is a collaborative work with the Yunnan University and the Xi'an Jiaotong Liverpool University. Recent ongoing outbreaks of COVID-19 has spread out at least 146 countries and has killed over 640,000 people in the world by July 2020. For effectively controlling COVID-19 outbreak, many countries have implemented different interventions like suppression strategies and mitigations, but both interventions have pros and cons. Our study aiming to build up a model to evaluate effect of multiple interventions to reduce healthcare demand and economic protection in the UK. Our proposed model was built on a traditional SER model, count for a dynamic, substantial, exposed, and infections and recovered and deaths population state. For estimating healthcare needs, we also categorize infections group into two subcases, mild and critical cases. Well, mild cases don't require hospital beds, but the critical cases need hospital beds, but possibly can't get it due to shortage of health resources. Also, there is a two feature in this model. One is a direct link between exposed populations and recovered population. The other ones we consider actual health demand by separating mild, severe, and critical cases. These two tables show the initialization of parameters. What we try to point out is one parameter to measure the intensity of intervention was defined to measure intervention intensity, average social distancing over time as MT, which was represented by average number of contacts per person per day. We also assume that the transmission ratio equals to the production of intervention intensity and the probability of a transmission when exposed. So from the results, we can see if we take in the suppression M equal to 3, nearly 26 times more infections in the UK than were reported as confirmed cases. Also, the suppression performed significantly impact on reduction of infections. A rapid decline in R has occurred in late March. But early suppression could reduce infections significantly, but may lead to an early peak time of healthcare demand. If we see the mitigation, that's equal to the M equal to 6, 8, or 10. Mitigation were able to delay the peak of COVID-19 breakouts in the UK, but ineffective to reduce total infections. Compared to the suppression, mitigation gave a slower decline in R, but it implies during this period there was still much growth of infection in the UK. Finally, if we see the multiple interventions, we simulated two possible rolling interventions. One is to keep suppression in London and take a 3 weeks rolling intervention in non-London area. The second one, we take a 3 weeks rolling intervention. Looks like the outbreaks appeared multimodal distribute trade over 315 days, longer than the period of suppression. But the two rolling interventions give a similar trait of R as suppression, but need to be maintained in a longer period. So to summarize our key findings, the longer period, like 4 weeks, lead to slight reduction of the total deaths, but the peak time of the healthcare demand nearly occurred at the same. Imbalance of total deaths and the human mobility restriction, 3 weeks period might be a feasible choice. If we maintaining a period of suppression in London, it was possible to control the outbreaks at 100 to 115 days that minimized the economic loss to the greatest extent. 3 weeks rolling intervention was appropriate to non-London regions for balancing the total infection and economic loss. There are also some limitations in our model, such as variety of plausible biological parameters and an accurate estimation of intervention intensity and the reasonable growth of available